Assalamu alaikum. Good evening. My name is Muna Ariqat, and I'd like to welcome you to the last session of the day, the conclusion of Badr in its 7th edition. Now I'm going to introduce Professor Petros Perros, consultant endocrinologist and visiting senior lecturer at Newcastle University in the UK. He will give us a state-of-the-art lecture on controversies in the treatment of hypothyroidism. So I think it's a pre-recorded lecture, so I hope it'll be a useful session. Thank you all.
Ladies and gentlemen, it is a great pleasure to be with you today, and I would like to thank Professor Hussain for the invitation. I'd like to take you back to 1891, because that was the date that this gentleman, George Murray, a physician practicing in Newcastle at the time where I'm based, made an important discovery. He produced an extract of sheep thyroid glands, which he injected to a patient with mixed edema, and the results were really miraculous. So the message spread very rapidly, and within a couple of years, thyroid extract became the standard treatment for mixed edema. So I'm going to fast forward 100 years later. In 1991, we held a centenary meeting here in Newcastle to celebrate George Murray's discovery. And I recall very clearly in that meeting, an eminent British endocrinologist made this statement, which I think is still true, although the treatment of hypothyroidism has become rather more complicated since then. And by the late 1990s, what became obvious was that a number of patients started to complain of persistent symptoms despite being on levothyroxine and asking for treatments that contained LT3. By the new millennium, we saw patient activists calling themselves thyroid warriors became very active in social media. And the kinds of ideas that were pushing was that endocrinologists and GPs don't know how to treat hypothyroidism, it is underdiagnosed, and that the treatments with T3 and desiccated thyroid extracts were far superior than levothyroxine. To the extent that by 2013, some patients took a petition to the Scottish government about this, and the demands were included the request that, in addition to the usual thyroid function tests for diagnosis and monitoring of hypothyroidism, that free T3 and reverse T3 should also be included, and that treatment of hypothyroidism should be essentially whatever the patient preferred, with the range being between levothyroxine alone as well as combinations with T3. Now, it took 5 whole years of meetings and consultations before the Scottish Parliament produced a lengthy report, and as you probably can imagine, it contained rather vague statements. Not surprising, because this is an issue that cannot be resolved, in my view, merely by politicians. But what also happened was that there was a huge influx of books and other material aimed at patients about the thyroid of dubious quality, shall I say. And the patient perspective of this, if you follow the social media, is that it's full of stories, personal testimonies of patients who have gone from levothyroxine to some kind of T3 containing treatment that has apparently miraculously transformed their lives. And it's not perhaps surprising that in the last 10 years, the use of desiccated thyroid extract, the material that George Murray used more than 100 years ago, actually increased twice in the US. And this is a trend that is at the moment experienced largely in Northwestern Europe, North America, and Australia. But I think it is spreading, and if it isn't already in your patch, it soon will be. So this phenomenon of patients reporting persistent symptoms triggered a response by the academic fraternity. And over the next few years, these three observational studies were published. They're rather similar to each other, and the conclusions from these are that between 10 and 15% of people on levothyroxine have persistent symptoms over and above those experienced by a comparative background population. And this includes patients who on levothyroxine actually achieve normal serum TSH. But as often is the case in life and in medicine and science, the devil is in the detail. And if one looks at these three studies on how they defined hypothyroidism, that definition was based on the patient receiving levothyroxine prescriptions rather than going back to the biochemical evidence of hypothyroidism. And this is an important detail, because in the last 10 years or so, what has become apparent from studies in North America, in the UK and Denmark, is that a significant proportion of people who end up on levothyroxine, up to 54% in one study in the USA, do not actually have hypothyroidism. They, if you go back, you'll find that the serum TSH was normal at the time of initiation of treatment. And furthermore, up to 70% of people on levothyroxine are on it because of subclinical hypothyroidism. And 4 years ago, this rather important study was published, which I think is very important, well-performed population study that looked at people with subclinical hypothyroidism who were untreated and studied them in great detail. And what came out of this was that such individuals with subclinical hypothyroidism do not have any more symptoms than the background euthyroid population. So, taking all these facts into account, it is my strong impression that the prevalence of people with persistent symptoms with hypothyroidism, despite being treated with levothyroxine, is quite a lot less than the 10 to 15% figure that is quoted very widely, probably closer to 1 to 2 or 3%, I would suggest. And combination treatment, of course, is gaining popularity. The question is this really the answer to this phenomenon? If you look at randomized controlled trials that have been performed in the last 30 years, and there's 20 of them, in fact, there's one more that was just published last week, you find that there is no evidence of superiority of one regimen over the other. And if you then go to the patient population and you ask them, rather than the controlled study type of design, then you find that even those patients who have gone on combination treatment, despite what is being said in social media, a very significant proportion of them continue to have symptoms, are still not happy with the treatment, and report poor quality of life. So, 30 years on, what is the expert opinion on this? Now, these are 4 reviews on the topic by 4 different groups of experts. And the one thing they agree about is that the randomized controlled trials show no difference. But if you consider a scenario like this, of a patient on levothyroxine complaining of persistent symptoms and achieving normal TSH, and you present these options of how you manage them, then 3 out of 4 experts would choose to switch to some kind of T3 companion treatment, and only 1 would consider alternative treatments that are not pharmacologically based. If you look at our professional organizations for inspiration in this topic, and this is the American Thyroid Association guidelines published 10 years ago, then their message on this topic is rather cryptic. The recommendation is against routine use of combination treatment. And the question is, what does this mean? And in a recent meeting, I put this to an audience of endocrinologists and asked them what do they understand by this. And this was the result. So you can see there is confusion about how we manage patients like this. So I think to explore this further, one needs to ask some questions. We need to think about all the possible causes for persistent symptoms, how patients perceive them, how they explain it to themselves, and whether there's something special about hypothyroidism. So over the next 20 minutes or so, I'm going to focus on some of these topics, and I will start with the causes of persistent symptoms. Now, the idea that levothyroxine does not achieve normal tissue levels of T3 in all tissues is something which is, has been explored quite extensively. And there is animal experimental evidence to support that this may be the case. And there are a number of other possibilities why people may continue to feel unwell. And of course, there are even more that aren't on this list. And an important point is that patients can have not just one, but several of these or all of these. But most of the focus of attention in the last 30 years in terms of research has been on the low tissue T3 hypothesis, and the rest have been largely neglected. So how do people perceive symptoms? I'm going to take a brief detour and share a personal story here. And I'll take you back to 1983, when I was a newly qualified doctor and I worked as a surgical house officer in this hospital. And one of my main jobs was to manage post-operative pain. And I had to learn this very quickly to try and titrate symptoms against medication. And this was pretty much in keeping with the ideas that I had been taught as a medical student. You have a disease which causes symptoms. The symptoms are proportionate to the severity of the disease. And you use a treatment to hopefully alleviate both the symptoms and treat the disease. And as a junior doctor, I saw patients with a variety of different complaints, which were perceived as symptoms. And after investigation, these turned out to correspond to underlying physical diseases. But this kind of idea was to be challenged. In my case, back in 1995, when I came across a case report in the BMJ. And so here, this is the report. This is a young man who was a builder. He fell off a scaffold and landed his boot on a huge snail. So as you can imagine, he had terrible pain. He was in agony and required megadoses of opiates and benzodiazepines to calm him down. This was the appearance of his foot. This was the x-ray, and what you do in the situation is you try to remove the boot but leave the nail undisturbed to ensure hemostasis, and so that's exactly what the doctors and nurses did. And what was revealed was really extraordinary. And what had happened was the nail had gone through the space between the first and second toe, and this patient's foot did not even have a graze in it. So here was an example of somebody perceiving excruciating pain in the absence of an underlying injury. And this reminded me of this iconic photograph, which some of you may have seen. These are soldiers from the First World War who have just been injured and they're receiving first aid. And I would like you to focus on this gentleman here who has just lost his left arm as a result of a shell. And if you look at him in detail, I think you would agree with me that this is not somebody who looks as though he's in pain, and I can assure you he had not received any painkillers. So here's an example. Somebody who had a most horrendous injury and yet he's perceiving no pain. So this idea that symptoms neatly corresponded to underlying disease processes went up in smoke overnight, as far as I was concerned. Now, neuroscience has some insightful answers to this, because this has been studied extensively. And it turns out that the sensory input that we have is processed by the brain, it's perceived as a symptom, but there's a number of other factors that feed into this process, which can amplify it. And conversely, the brain, rather like the foot of the scaffolding worker, the brain, in addition, has filters that it can apply. And so other factors also come into this process that can actually downregulate the signal, like the soldier from the First World War experiencing no pain. So symptom perception is a complex process. In addition to the underlying stimulus, there are a huge number of other factors that feed into it and modulate it. And then there's the question of how do we explain symptoms? And this is the same principle as trying to make sense of something that happens to us. We all do it. And particularly if it's something bad that happens to us, there's almost an instinctive need to blame something or someone. And there's no better example of this than the original sin. And here you can see in this beautiful painting by Domenichino, the rebuke of Adam and Eve, God being very angry at Adam. And what does Adam do? He's saying, well, it wasn't me, it was Eve. And Eve in turn says, well, it wasn't my fault, it was the serpent. And this is what I call the hypothyroid equation. When you have a diagnosis and you have additional unexplained symptoms, it's extremely tempting to blame it on the diagnosis. Sometimes justifiably, but in my view, not always so. So what's special about hypothyroid symptoms? Here's an example. Somebody presenting with fatigue, with nothing else really in the history or examination. And the question that arises is what is the likelihood that such a person has hypothyroidism? And there are data on this. There's the likelihood ratio, from which tells you something about the chance of this happening, which happens to be 1.4. And then there's this very important concept, the pretest probability, that all of us should have at the back of our minds before we order any tests. And again, the data for the prevalence and the likelihood ratio are known. And if you do the maths, then the pretest probability for somebody presenting like this is 0.8%. So what that means is that you will have to test 125 patients like this to actually diagnose one with overt hypothyroidism. And if you look at all the so-called classical symptoms of hypothyroidism, they're all associated with very low pretest probability. So people have gone further and combined symptoms and signs to see if we can improve that. And yes, we can improve it, but not very much. And another important point that's worth thinking about is how do symptoms correlate with biochemistry in hypothyroidism? So if you look at the extreme end, patients with myxedema, then there is a correlation with symptoms. But if you then go to the other end, mild subclinical hypothyroidism, numerous studies have shown no correlation between symptoms or quality of life with any of these biochemical parameters. So I guess I'm telling you what you already know, that the symptoms of hypothyroidism are non-specific and they don't correlate well with biochemistry. But it's an important message that's worth just repeating. So symptom perception is already complicated, but it looks as though there's further steps. The patient narrative of how they perceive, how they explain, who they blame is important. And then that feeds into quality of life and dissatisfaction. Now, these are data from conditions and diseases other than hypothyroidism, and I think the important question is, how does this apply to hypothyroidism? And so I'd like to tell you about a study that I was involved with. This was a survey of patients with hypothyroidism in collaboration with the patient-led organization, Thyroid Federation International, and the Picker Institute, which has expertise in performing patient surveys. And we got nearly 4,000 responses from patients with hypothyroidism from all over the world. And the idea was that we wanted to look at several variables that are of importance, such as satisfaction, quality of life, control of symptoms, and see how they relate to other parameters that were recorded. Now you will see that somatization, type D personality are included, and these are the definitions of these two components, and there are validated questionnaires that were embedded in our survey. So just the somatization is what we used to call hypochondriasis, but not allowed to use that term anymore. And type D personality is kind of the type of person that feels that the glass is half empty. And so the first thing to say is that the prevalence of somatic symptom disorder in this population of hypothyroid patients was really very high, nearly 60% compared to the background population. And the prevalence of type D personality also rather high compared to the background population. And then we found that dissatisfaction was associated with a number of parameters that have nothing really to do with hypothyroidism, but they were demographic, trust in doctors, somatization, type D personality also were important in shaping up dissatisfaction. And the poor quality of life was, and poor control of symptoms was associated with somatization and type D. And in this study, quality of life was actually better in patients on levothyroxine. Then we looked at how patients actually interpret their symptoms. What do they blame for them? So first of all, we looked at patients who had symptoms, but they did not have somatic symptom disorder. We asked them whether the symptoms were attributed, whether they attributed them to the hypothyroidism. And here's the result. So it was only the minority out of this group that blamed thyroid or its treatment. But then when we looked at the group of patients with somatic symptom disorder, it was a completely different picture. The vast majority blamed the symptoms on the hypothyroidism or its treatment. And this wasn't just for symptoms that we associate with hypothyroidism, but also with a variety of other symptoms that are not really known to be typical symptoms of hypothyroidism. Now, I'm going to take a little bit of a deviation here and talk to you about this website, which is run by patients. And I've picked it because it's extremely popular. There are many like this. It has apparently over 1 million followers. Lots of patients go to it and get information from it. And there are 4 very clear messages that this website gives to the followers. Number 1, that there is no symptom known to mankind that is not a symptom of hypothyroidism. Number 2, don't trust blood tests, they're misleading and unreliable. Number 3, if you have symptoms, then you should be treated with thyroid hormones. And number 4, that may not be enough and you might need some supplements which conveniently you can sell in our website at extortionate prices. So this really inspired us to look in our survey of patients at misinformation. And we defined misinformation, the belief that people with hypothyroid-like symptoms and normal blood tests should be treated with thyroid hormones. And we found that half of the respondents to our questionnaire actually were misinformed. And misinformation was associated with a number of other important parameters, with overtreatment, with treatment with T3, with daily use of social media, lack of trust in doctors, dissatisfaction, poor quality of life, poor control of symptoms, and also where patients lived. So if we go back to the slide I showed you before about all the various potential causes for persistent symptoms, then this survey certainly has provided for the first time some evidence that somatic symptom disorder may be an important part of this phenomenon. And in addition, it has provided some evidence that personality is important, demographics, trust in healthcare professionals, and misinformation. Now, these of course are not robust pieces of evidence, but at least there is enough upon which hypotheses can be built and tested. So, what I've talked about so far is persistent symptoms in people with hypothyroidism, and this is a terminology that is used in other areas of medicine. And in fact, there are lots of different terms that describe this phenomenon. Some of them are synonymous, some of them are overlapping, and it's a rather confusing area. But in the last 10 years or so, the term medically unexplained symptoms has become much more established, and it kind of embraces all these other terms. So these are some examples of common symptoms in patients with medically unexplained symptoms, and you will see that some of these overlap with the symptoms of hypothyroidism, perhaps not surprisingly. But there's an important thing to say about this topic, because there is a lot of confusion about it. So medically unexplained symptoms are not factitious symptoms. These are not symptoms that your patients are using to try and deceive their doctors. They are experienced as real, and they're distressing and disabling for patients. And you will see variants of this just about in every specialty. So psychiatrists call it conversion disorders or somatic symptom disorder. Neurologists, functional neurological disorders, fibromyalgia in rheumatology, irritable bowel in gastroenterology, postural tachycardia syndrome in cardiology. So there are variants of this that appear in every specialty of medicine. And it is common, in fact, it is commoner in specialist clinics in secondary care than in primary care. And it has been estimated that in endocrinology, which falls within general medicine, 40% of patients have medically unexplained symptoms. Now, most of them also have an endocrine diagnosis, and the two go together. So, how does one manage medically unexplained symptoms? Well, first of all, there's no easy diagnostic test, unfortunately. This is a diagnosis that is made by exclusion, and one has to rule out undiagnosed comorbidities. One has to optimize the treatment of known comorbidities. And remember, patients with hypothyroidism have usually a lot of other comorbidities, much more so than the background population. And one needs to optimize levothyroxine treatment, of course. And one has to remember that if a snapshot serum TSH is normal, that doesn't necessarily mean that your patient has not had poor control of hypothyroidism with thyroid blood tests way off the normal reference range a few weeks previous or a few weeks afterwards. So, having gone through this process, if there's no medical explanation for symptoms, then the patient may be considered as having medically unexplained symptoms. So, how do you manage it? Well, there's a very simple intervention that is helpful, and that's just to listen to patients and take them seriously. And empathy can have a therapeutic effect for some people. There's some important do nots. So avoiding over-investigation and passing them on from specialty to specialty is important. One has to really put an end to this once you've ruled out the usual things, and then just keep an eye, and if symptoms change, that would be a trigger for doing more investigations. But this merry-go-round of investigations and opinions can be really counterproductive and can exacerbate the patient's anxiety. I think it's important when we're faced with such patients that we get help from experts that actually know and have been trained how to manage such patients. And I can only talk about endocrinology in the UK. Certainly, endocrinologists in the UK do not get any training on how to manage such patients, so really don't have expertise. So it's important to help from other professionals, such as the family doctor or the psychiatrist or psychologist. And of course, communication is hugely important. So clear messages to the patient and good communication channels with other professionals is really important. For some patients, just reassurance may be enough. Reassurance that they don't have something terrible or life-threatening to explain the symptoms. And in some cases, the medically unexplained symptoms may be an underlying symptom for depression and anxiety that needs to be managed. And there is some evidence that CBT and exercise training may be helpful, and these two papers specifically have looked into this in patients with hypothyroidism with promising results. Social prescribing is popular in primary care in the UK, but I don't think there's much evidence for or against it. And so, what can we infer from all this? Well, I hope I showed you that the poor quality of life and dissatisfaction with hypothyroidism is a complex matter. And I showed you some evidence from the large survey that we conducted that we can now identify some of these factors. And this is enough, I think, for putting hypotheses together that then can be tested and see how this really fits in the management of hypothyroidism. I think we need to broaden our horizons about how we manage patients with hypothyroidism and persistent symptoms beyond that narrow concept that it's all down to T3. It is a multifactorial situation. We need to be aware of that. And my view is that non-pharmacological approaches are likely to turn out to be much more effective and less potentially harmful than changing the hormonal treatment of these patients. I think misinformation is a very important part of it, and clearly, in my view, is associated with poor outcomes and patient exploitation. And it was exactly this that inspired me to write this book for patients, which tries to navigate and lead them to trustworthy sources of information. Thank you very much for your attention.
Our thanks to Dr. Perros for this enlightening talk. I'd like to thank you all for hanging in there until the end. And we'll see you tomorrow with another thyroid talk. It's thyroid disorders in pregnancy, tomorrow morning at 9 o'clock. And I hope you'll have a rich and very useful sessions tomorrow. Thank you all.